Hi, it's Eileen Spillane from Befriending Death, and I just wanted to talk a little bit about advanced directives. So if you are hospitalized and you are of sound mind and have capacity to make decisions, you don't need to be thinking about having a healthcare proxy or an advanced directive. But there's some situations where you might find yourself not of decision making capacity. So in that case, you will want to have advanced directives. And 1 in 3 Americans do not have an advanced directive, including people who are of advanced age and have comorbidities and chronic illness, because we just don't prioritize it. We don't have those conversations with our providers. Our providers don't initiate those conversations with the patients most of the time. You're limited in the amount of time that you have in a doctor's visit in the first place. And most of the time, death makes us feel uncomfortable, so we don't want to really talk about it. But if your wish is to die at home, you got to do a lot more than just wish about it. You've got to have the documents. You've got to stop, some treatments when that becomes an automatic thing. You've got to let people know what your wishes are. So we'll go over this. The most important advanced directive is having a durable power of attorney for healthcare. So this is different than finances. This is only about healthcare. And it's often referred to, if it's not a DPOA for durable power of attorney for healthcare, it's often referred to as a healthcare proxy. So basically, a healthcare proxy is someone that you have legally authorized to make your healthcare decisions for you when you are not capable of doing that. Whether you're in a coma, you're unconscious, if you have cognitive decline, those are examples where you're not of decision-making capability. Now, it's important to know when you are choosing your healthcare proxy, that needs to be done when you are of sound mind. So this can't be something that's done in the later stages of dementia. It needs to be done when you are able to make those decisions for yourself. So, what qualities are you looking for in a healthcare proxy? First of all, no one wants to really sign up for the job. So you want to thank someone if they're willing to take on this position for you. You want to be really clear with them to let them know what your wishes are. And you want it to be someone who is of good communication ability, who's not going to be super reactive, who's going to have a strong backbone, who will stay calm in a crisis, who will be centered and grounded and be able to express what your wishes are. So sometimes people choose people who are very close to them, but they're not able to release them. They're not able to follow those wishes. So that might not be the right person for you. Sometimes people choose a spouse, sometimes they choose a friend, sometimes they choose a family member. Sometimes it's even a legal person who's not necessarily a personal friend or loved one. And in those cases, you want to really be aware that you're putting them in a situation that's a very emotionally tasking position. So the more clear you can be about what your wishes are, the better it is for your healthcare proxy. If you don't have one, you complicate that by depending on what state you're in, it's going to fall to the next of kin. And so oftentimes there'll be people who are living together and partnered for life, but they have not legally partnered or legally married. So in that case, they don't have the legal right to decision making unless you've appointed them as a DPOA or a healthcare proxy. So that's something to think about. And depending on what state it is, it could fall to a parent, it could fall to a child, and you may have more than one, you may have multiple children who may not actually agree and be on the same page, or you may have siblings that may not be all on the same page. It all sort of falls on what your unique family dynamics are. And if you are in a family that has more complexity to it, you're going to have stepchildren, you're going to have like a previous partner who might say, well, Joe always said this to me, I know that he wouldn't want this done. So these are all things to be aware of, that you can create a lot more ease for your loved ones by getting everything really clear, picking the right person to be your healthcare proxy, and then actually writing stuff down, writing down what your wishes are, so that they have that to fall back on when you are not able to communicate your wishes on a regular basis with that person. And some of those ways you can write down is an advance directive, such as the 5 wishes or a living will. There's also compassionate choices. So there's some tools, and I'll mention them at the end of the video so you can reference them. But in those, you can be a little bit more specific about, in this scenario, if X happens, I don't want Y and Z to be intervened with, or something a little bit more specific. So some of the terms that you'll encounter under the umbrella of advanced directives is DNR, which is do not resuscitate. So that means if your heart stops beating, you do not want it to be brought back to life. If you stop breathing, you don't want to be put on a respirator and be brought back to life. So there are some circumstances where people feel like, oh, I want everything done, and that's great. There's a decent chance that you'll recover and have a spontaneous return of circulation and go on and live a nice long life. I know of cases that has happened. Somebody had a heart attack on the bike at the gym, and my friend happened to be there and resuscitated him, and he is alive and well to this day. So he was somebody who was fit, who was healthy, did not have a lot of comorbidities, did not have chronic illness. So his chance of recovery and intervention was very quick. So his chance of recovery was great. For somebody where they have been down without a pulse for a long period of time, that's going to interfere with a quick recovery. They may eventually get the heart to start beating again, but maybe there's going to be no brain activity, or other organs were impacted by not getting circulation to that area. If someone is chronically ill and in the hospital and is not really ready to be a do not resuscitate and receive CPR, sometimes the chance of recovery is not good for someone who has chronic illness or terminal illness, because there's already so much injury and weakness in the other organs. So that's just something to consider when asked, do you want to be resuscitated? It's good for each person to reflect on their unique body, illness, age, all of those factors at the time. There's also something called a do not intubate, or DNI, and that is along the lines of do not resuscitate, but that might be a situation where someone has significant pulmonary or lung damage that they may not be really ready to be a full do not resuscitate, but they understand they don't have a good chance at recovering from being on a ventilator for an extended period of time. And in those cases, sometimes they'll receive CPR, or they'll receive medication that is dripped into the veins in the ICU that is basically keeping the heart pumping in a way that's like a chemical compression with medications just to keep the heart functioning. There's another term called MOLST or POLST or MOLST, And that stands for Medical Order for Life-Sustaining Treatment, or Physician Order for Life-Sustaining Treatment, or electronic version of life-sustaining treatment. And those are legal documents that you and your physician have come to terms with that will be defining like some of the choices that you make at the end of life, whether you want to be resuscitated, whether you want to have CPR, whether you want to be on a ventilator, whether you want dialysis, whether you want artificial nutrition such as a feeding tube. All of those things could get addressed in a POLST. And we don't really see them very often in the hospital. Hospitals will more often direct towards a do not resuscitate. And a POLST or a MOLST will often be seen in homes where people are aging in their home, maybe on palliative care or hospice care or just normal aging. Or they might have this form in a skilled nursing facility, rehab center, or nursing home. And that would be sometimes at the foot of the bed in a nursing home or on the fridge in someone's home. And that is really for paramedics. So when paramedics arrive, if there's been an emergency, of any kind, could even be simply a fall, and the nursing home might call 911, if for whatever reason you stop breathing or your heart stopped, you want them to know what your wishes are. And so the POLST form would be at the foot of the bed there, and the nursing home would have a copy of that as well. One other thing to mention about the do not resuscitate is most of the time, if you need a procedure done that is requiring some kind of anesthesia, even conscious sedation, or a surgery that is involving you going in the operating room and receiving anesthesia, almost 100% of the time, the physician will rescind your do not resuscitate order, because you're already going to be in a situation where you're going to be needing life-sustaining measures to keep you alive for the anesthesia for the procedure. There are very rare exceptions to this where someone is on palliative care and it's a comfort measure. You may get a physician, a surgeon, and an anesthesiologist to sign off and say, yes, we will maintain this DNR order. But for the most part, that's not going to be the case. That's a rare exception. So hospice and palliative care is another term that you'll come across in this area. So palliative care is where the priority is for the patient is to put comfort at the center. So symptom management, pain management, comfort care, while we are still treating the illness. So that is different than hospice, where hospice is a time in your life where you have come to accept that you're no longer going to be working towards a cure of your disease. And with hospice, it can be very palliative because you're also prioritizing comfort and symptom management, but you're no longer working towards getting rid of the disease. You're now choosing to allow natural death to happen when that happens. Where palliative care, sometimes that can be really helpful for someone with a chronic illness such as congestive heart disease or chronic kidney disease, lung disease, things like that, palliative care can be really, really helpful. It also reduces the number of hospitalizations that you have. And when you stay out of the hospital, you have fewer hospital-acquired infections, you have fewer incidences with medical errors. So, and you're much more comfortable if you can be, aging in your home. And when you're getting worked up for your illness, it could be helpful to ask your physician a few questions. So, like an example of a question could be, someone with my illness, what would I expect the normal course of treatment to be for this? And what medication could ease my symptoms So then you're prioritizing like your symptom management. You're not necessarily like all about the cure. Maybe you are, and that's also really helpful to be clear of like, I'm willing to do anything. Symptom management, pain management is a low priority, but cure is my number one priority. Really good to get clear so that you and your physician are on the same page. And another question you could ask is like, how is this test that you're ordering, how is this going to change the course of my treatment? And if it is, that's great, let's proceed. But if it's not going to change your course of treatment, why bother going through this unnecessary test? If you have to lie flat and that's uncomfortable for your lung condition, or if you have to swallow barium for some tests that may not provide any kind of change in your treatment care, maybe you don't need to have that test done. And if you do choose to opt towards palliative care, you can ask the physician, will you still be my physician if I go on hospice care or if I go on palliative care? And you can ask, which type of patient would you recommend with my illness that would go on hospice care? And that just sort of opens up some opportunities for conversation with your physician, because your physician's not going to know, they're not going to read your mind, they're not going to know what your wishes are. So, and they often will hesitate because they want to anticipate that you're looking for cure and at all costs. So it can be really helpful for you to initiate this conversation. One thing to keep in mind with hospice is that hospice is available, and they will come as a consult. You'll see them a little bit more initially and at the end of life. But when you're kind of in autopilot mode, they're not really going to be a strong presence. You can opt in for something called an end-of-life doula or a death doula. And they are similar to birth for people who sometimes will opt to have a doula at their birth. They are not medically trained, but they are there to prioritize your comfort. And that is centered on how you want to use them. And so sometimes a death doula is there, sort of to support your making your day a little bit more comfortable. Sometimes they might help you with a legacy letter if you want to write letters to your children, or maybe help start difficult conversations with friends and family, help be a gatekeeper to, if you're getting inundated with visitors, maybe help with a meal train, various different things. And each death doula will carry different strengths, so you can work with them, and they're very affordable. I highly recommend them as a support. Then another term to think about is VSED, and that stands for voluntary stopping eating and drinking. So that is for people who are just at the end of their life and they don't want to extend it. It's not necessarily as painful as it sounds. When people think about that, they think, oh, that's starvation. But the body, the organs are shutting down anyway, and they're not able to handle a lot of food and fluids. So it can be a really natural way to allow death to occur and not prolong the suffering any longer. Then there's also medical aid in dying, which is also known as death with dignity, and that became legal in Oregon in 1998. And now there's a lot of states that have followed. I believe there's about 11 states that's now legal in, and more states are starting to change their laws so that it'll become legal in other states. But Washington followed, Montana, Colorado, California, DC, Hawaii, Maine, Vermont, New Mexico, New Jersey. So there's a lot more traction around that. And that requires, that's a situation where a patient is in a prolonged illness that is creating extra suffering on some level physical, emotional, spiritual, whatever, where there's two physicians that have agreed to sign off and allow this medical aid in dying, and a medication is prescribed to the patient gets it filled, holds it in their home, and at some point in their illness, they decide when they want to take that medication. Now, that medication needs to be administered by the patient themselves, not by a healthcare provider, and not by a family member. So that's orally given, they swallow it, and their death will proceed shortly after that. Most of the time that happens in their home. So in that case, sometimes there'll be some hospice person there or a death doula there to help support the family around that. And that is different than euthanasia. So, which is illegal in the United States. Where death with dignity, there's a lot that goes into this decision. There's counseling, there's palliative care and counseling. There is 2 separate times that the physician has to discuss this with the patient. So it's not just a flippant decision. And there has to be a significant amount of pain and suffering involved. So with euthanasia is legal in Canada and in some places in Europe, like the Netherlands, Luxembourg, Belgium, and that is where there's extensive amount of suffering that the physician will actually administer something to the patient to end the life. And of course, that also has lots of discussion and counseling involved before that happens. So other resources that you can check into, to get support around doing this legal document paperwork is the Conversation Project is one. Compassion and Choices is a great one because that goes state to state and that could be tailored to where you live. There's also mydirectives.com and 5 Wishes. So just to keep in mind, these are great things to write down. They're not always legal. So the legal things are the POLST, the DNR, and the durable power of attorney for healthcare or healthcare proxy. Those are the most important ones, but going through these resources can be really helpful for you to start thinking about, what are my wishes? What do I want? How clear do I need to be to my family and friends or loved ones who are in this situation where they have this very important job of making your decisions for you when you're unable to do so yourself? And it's worth noting to revisit these documents every year. Make sure that the person you've assigned has not predeceased you, and make sure that that person is no longer, not married to you, or you're still on the same page emotionally with this person. Because relationships change, and you want to make sure you're giving the power over to someone you trust, someone who can communicate well, someone who can advocate for your wishes, especially when met with a strong physician who may want to keep you alive, and that might not be your wish. So I hope this helps. And if you have more questions, you can contact me at befriendingdeath.com.